Welcome, everybody. What a delightful evening, even though we have some raindrops blessing our home. Today, I'm really excited to have all of you here, and on behalf of the University of Manitoba, the Office of Research Services, the Vice President's Office of Research, we are really honored and pleased that you could come out for another Café Scientifique. And this is a terrific opportunity. It's an informal discussion. I am Dr. Brenda Elias. I'm from the Department of Community Health Sciences at the Faculty of Medicine at the University of Manitoba. I'm a CHR investigator. I've been very fortunate to have written a number of grants that have been successfully funded. One of the grants was on health indicators and reporting on the health status of the First Nation population in Manitoba. And it was about, and is still about, producing actionable statistics on trying to close the gap and address health disparities. And today I am with two incredible colleagues. First is Dr. Anne Fanning to my immediate right. Dr. Fanning has joined us here at the University of Manitoba as an external on one of our students' projects on TB. She is a professor emerita from the Division of Infectious Diseases and the past coordinator of the Global Health Initiative in the Faculty of Medicine and Dentistry at the University of Alberta. She is also the chair of Stop TB. She has been involved in the clinical care of tuberculosis patients for over 20 years and is strongly interested in the epidemiology of tuberculosis in Canada and globally. Dr. Fanning is dedicated, and I mean dedicated, to working for global involvement in the fight against infectious diseases. She has worked with the World Health Organization and others to promote education and training in fighting tuberculosis and other communicable diseases. She was appointed a member of the Order of Canada in 2006 in honor of her efforts to fight tuberculosis. And to Anne's right, our colleague, Dr. Pamela Orr. Dr. Orr is a researcher, clinician, teacher, and administrator in the field of infectious diseases in Aboriginal and Indigenous populations here at the University of Manitoba at the Faculty of Medicine. She has a particular interest in tuberculosis and is currently focusing her research on the agent, host, and environmental factors affecting TB in Canadian Aboriginal and other Indigenous populations, such as populations in Russia. Dr. Orr is president-elect of the North American region of the International Union Against Tuberculosis and Lung Disease. So a warm, warm welcome for these very honorable and incredible women. So the ground rules of this event is that our speakers will do a 5-10 minute presentation of their expertise, and then we'll open up the floor. We're going to start first with Dr. Orr and then followed by Dr. Fanning. The floor is yours.
Thank you. Actually, I noticed many people who are quite a bit more qualified to speak about tuberculosis in the audience, including several people who taught me most of what I know, which isn't in books, including Joanne McMorran, who's sitting over there, and Nancy Williamson, who's sitting over there, and Velvet Maud here, who's done some wonderful work basically documenting the narrative experience of her own grandmother, I believe, through tuberculosis. I also suspect there are quite a few people in the room who have actually had tuberculosis, and there's probably nobody in the room who hasn't been touched by someone dear to them who's had tuberculosis. So I just wanted to acknowledge that. I wanted just to say a few words at the beginning, kind of a TB 101, so I don't want to dumb it down or talk it up, but just to make the setting clear, tuberculosis is a bacteria, so it's a very small creature that we can see with a microscope. It can stay in the air for long periods of time. It's passed from person to person through the air. So if there was someone tonight, and hopefully not, but who was coughing, who had tuberculosis disease, the bacteria could go into the air and then follow air currents, and we could breathe it in. Some of the people in this group would not breathe it in, and other people would breathe it in. If you breathe in the tuberculous bacillus or bacteria, 90% of people will, or let's put it the other way, only about 5 out of 100 people would actually go on to get disease, become sick, in the first several years after breathing it in. The rest of the individuals would breathe in the bacteria and it would live in your body but not cause sickness. Up north we call that sleeping TB. It's a hard concept to understand that you can breathe in a bacteria and it can live in your body but not actually cause any harm. In medicine we call that latent tuberculosis. And you can live 80 years or 90 years and go to your grave and still have the bacteria alive in your body but not causing any harm. So some people, a very small number of people who breathe in the bacteria become sick right away in the first 5 years, but most other people would have it latent in their body, and a small percentage of those people later in their life, it could be 20 years later or it could be 80 years later, can reactivate the bacteria, so it starts to wake up and multiply, and then it can cause disease. Once again, that's only a very small proportion of people who carry latent TB in their body. And we call that reactivation tuberculosis. And TB is a disease of humans. There's cousin bacteria that can cause disease in cattle and buffalo and elk, as Anne well knows. Anne's from Alberta. We can get her to talk about the elk outbreak of TB. The diagnosis is usually made by getting people to cough up sputum, and you stain it and culture it. But of course TB can be in other parts of the body. It can be in the brain or the bone. And in that situation you might have to look quite hard, even get a biopsy to make the diagnosis. There are treatments that have been available since the 1940s and 1950s, but you have to use multiple drugs. You have to fight the war against this organism using several weapons, which are antibiotics. You can't just use one, and it takes a long time to cure it. Usual treatment is around 9 months. If you have illnesses in your body, diabetes or HIV or cancer, you're more likely to go from the latent stage of TB to disease. You're more vulnerable, and the treatment often needs to be more vigorous. Many people in this room might think, gee, TB, I thought it was gone, but it's not, and we'll hear the reasons why. So I think I'll stop there. That's a kind of a TB 101. And then I would say that we tried to get, there should be a third seat here, because we tried to get a patient or someone who had experienced TB to come and talk about their experience. And I actually phoned a number of patients, and I thought a number of people considered it and said yes and then no. And finally I thought I had a great person, in fact a physician who developed TB. This physician agreed and then didn't agree because her family were worried about the stigma associated with TB, which says a lot. If a doctor is not comfortable to come and tell her story, what about other kinds of people who maybe have less self-confidence or chutzpah or whatever it takes to get in front of an audience? But she did agree to write her story. So I'm going to read it. It's slightly longer than I thought, so I may abridge it, but I think we have a lot to learn from her story. So she starts out by saying she'd initially agreed to be interviewed, but I am by nature a soft-spoken and shy in front of an audience. She thought that sharing her TB journey would be one way to destigmatize tuberculosis, to show in this day and age that the stigma of TB only exists due to misinformation and regressive thinking. My husband, however, was very surprised at this decision, knowing how much I value my privacy. He cautioned me about how it was not just me being exposed to scrutiny, but my own family members. And these family members might not appreciate the intrusion into their private life. So I regretfully declined a personal appearance at this time, but I hope the audience understands that maintaining anonymity doesn't always mean that one is hiding something. So her first chapter is entitled, "I'm Invincible, It Can't Happen to Me." My grand aunt was the first woman graduate of a university in my country of origin, outside Canada, and the first woman physician to graduate from that institution in 1912. She was widowed in 1924 when her husband, who was a surgeon, succumbed to tuberculosis. She had directly cared for him during and throughout his sickest days. I recall my father, the son of this doctor and the surgeon, saying on several occasions that his mother had said, "We do not have TB in our genes, so it's not likely that our family will get the disease." She had claimed that even if she had been in constant and close contact with her husband until the day he died, she never acquired the disease. She survived breast cancer in the 30s and died in 1967 of heart failure. So this is the doctor who didn't come tonight, had always felt invincible, having heard this from my father. Quote, "It is unlikely that anyone in our family will get TB." This sounded pretty good to me. So then she talks about her personal journey. I was diagnosed to have pulmonary tuberculosis in late April 2010, quite incidentally. I have bronchial asthma, and every winter it would not be unusual for me to experience a prolonged cough. My symptoms would last 6 weeks. I would use inhalers, and every few years I would use some oral steroids. In the winter of 2010, I experienced coughing spasms, and these responded to my inhalers. I did not have fever, I did not lose weight, I did not have any other symptoms. But because I had had a pneumonia a year before, my doctor told me to have a follow-up chest x-ray. So when my cough did not resolve, my husband told me to go and have my chest x-ray. I was shocked when I looked at my own chest x-ray films because there were changes there that did not relate to my previous pneumonia. I talked to the radiologist, I talked to my own doctor, and a CT scan was ordered. And I had that CT scan 5 days later. Obviously, she maybe had more pull than the rest of us to get a CT scan in 5 days. But, two CT scan radiologists read my films, and they strongly felt that the changes were due to tuberculosis. So I phoned Dr. Pamela Orr, that's me, and I asked her what to do. She was actually on call and in the hospital looking after patients. So I told her she had to go home immediately, which created a ripple effect in the hospital. All hell broke loose. So anyway, she writes, to confirm the diagnosis, she had some sputum samples sent. The first was negative, the second was positive. Learning this was to some degree a relief, as this meant that treatment could be begun. I found that interesting, that she was actually relieved to be told that she had tuberculosis. Isolation. So first things first, there was a high likelihood that I was contagious, and that meant I had to go on home isolation. And because TB is a reportable disease, public health was informed about my name and my status. My husband did not seem bothered at all about all this. Only my youngest child was living at home, but we'd all been traveling together. So public health decided that they were going to test all the members of my family. Fortunately, my husband and all 3 kids were tested negative on skin testing. So that's an example where they spent time with someone who was infectious, and yet they didn't even develop the latent or sleeping TB. Personally, I was not particularly worried by the diagnosis either. I knew it to be a disease that was treatable, and I was diagnosed early. And what was bothered me the most was I was placed under home isolation, and I couldn't go to work, and I was bored crazy at home. So treatment, she has a couple of paragraphs here about all the pills that she had to take, which were voluminous. And she was in fact allergic to one of the medicines, so she had to go on a stand-in medication, and she was worried about this. Eventually she saw an allergist and was sort of desensitized and went back on the original medicine called rifampin. But every time she took the pill, she would feel itchy and have a few little spots, which is pretty nerve-wracking. So every day she had to take about 16 pills, and they always made her nauseated, and she gave her an upset stomach. So she describes her treatment with numerous pills, and then eventually they were decreased in number. But she received all her treatment under what's called directly observed therapy, or DOT. So that means that someone came to her house and watched her swallow the pills. Overall, it wasn't bad at all. Someone would come to the house and later to my place at work and watch me take the pills. It was no big deal. The system was quite accommodating during that time. I was aware that when some patients and their families hear that they have to be watched to swallow their pills, they react with disbelief and, quote, "How dare you distrust my ability to take my own medicine," unquote. I'm a professional. But she says that she actually found it a supportive resource. She actually felt that someone else was looking after her, which is interesting. She didn't mind that. Where did I get the disease? Being an immigrant to Canada in 2000, I wondered about whether I had come to Canada with this infection from my own country. Technological advances allowed genotyping of the organism, so she sent the sputum to the lab where it was tested and identified, and then there was a special kind of fingerprint done of the organism. It turns out that the type of fingerprint that she had is similar to the fingerprint in an outbreak from a northern community in Manitoba that started in 2010, a reserve community. And she looked after people from this community. I'm not the first physician to acquire the disease from a patient, unfortunately, and neither will I be the last physician to be infected from a patient. I had examined and treated numerous patients from this outbreak, and little did I realize that repeated exposures would result in this disease. Although becoming a TB patient throws out the theory of genetic invincibility, I continue to believe that there is likely a genetic susceptibility to TB, which is only compounded by multiple inherent and external risk factors like nutritional status, other illnesses, the environment. Her outcome now, she says, "I feel great. It's been over 2 years since my diagnosis and treatment. What has persisted, though, is a major frustration with the system, because my concerns about workplace safety for physicians and my request for improved conditions have been ignored. Despite notifying hospital management about the continuing risk and potential of risk for staff and for patients to be similarly exposed and to develop disease, no measures have been taken to improve my workspace." And she ends by saying, the reply from Workers' Compensation Board of Manitoba was that from the nature of my work, being a physician, I had acquired the disease through my own doing. So, and then she just ends. So I want to pay tribute to the courage of this doctor to tell her story and to have such a positive outlook on her journey. Many people have not as chipper a story to tell, and other people have also, better stories than this in terms of their journeys. So, so I'll stop there. Thanks.
Oh, thank you, Pam. And thank you for the sharing of the story. That's terrific. Thank you. And
yeah.
I call them to you.
But I'm really honored to be here to have an opportunity to talk about this issue, which I think is, it's really a challenging one. So I would say that while you're probably all here because you have some interest in TB, you may be surprised that this disease is so common globally. It's almost gone in Canada, except for some instances like Pam has talked about, for at-risk people, for people born outside of Canada, for health workers, for people in poor and marginalized communities, and this particularly applies to Indigenous people. But globally, it's the second commonest cause of death due to a single pathogen. There are about between 8 and 9 million cases annually, and about 1.4 million deaths. And in fact, it's only number 2 cause of death due to a single pathogen to HIV as a cause of death. And in fact, TB is the commonest cause of death in HIV patients. The two diseases overlap intimately because TB actually aggravates HIV. It drives the immune system to try to respond, and that immune system that has its little virus particles in it magnifies the number of HIV organisms present. And on the other hand, HIV diminishes the protective cells, the immune competent cells, and allows that sleeping TB to reactivate. So in fact, Pam said that those who have been infected years ago, and I was infected about 30 years ago, and have never had any symptoms at all, so I count myself one of the 19 out of 20 who will never get TB. But should I get HIV infection tomorrow, my risk of developing TB over the next decade would increase tenfold. It would be an almost certainty that my TB would reactivate. The same would apply, not quite as significant a factor if I had a kidney transplant or if I had to go on immune suppressive drugs, my risk would increase. So this is a disease that, although it has small numbers of cases in Canada, there is a significant group of people who are at risk. Now globally, let's suppose that physician were in sub-Saharan Africa and had a bit of asthma. What would her circumstances have been in terms of seeking care? She might have been lucky enough to be a physician and have immediate access to care and smart enough to know that it might be TB, but instead of having 300 doctors per 100,000, there are 3 doctors per 100,000 in this African country. And the access to the diagnosis, which for her was a CAT scan, I mean, there's probably no CAT scan in this country where she is, the chance that the diagnosis would be made promptly within a week or 10 days is exceedingly low. So globally, those 8 to 9 million cases have access to simple diagnostics like microscopic examination of the sputum that has to be transported to the lab, probably by walking there, The report probably takes weeks to return. There's certainly no fingerprint of the organism to know where it came from. But there is globally available really good quality treatment. And I wanted to acknowledge what Pam has already said, that treatment for tuberculosis has been available since the 50s. Good treatment, combination, somewhat hard to tolerate drugs, but not high-risk drugs. And the effectiveness of these drugs is well over 85% are cured if the drugs are taken, and thus the observed treatment. This is a global standard. And those drugs, and I want you to write this number down, for 6 months of the drug supply costs $13. That's 4 drugs for 2 months and 2 drugs for 4 months, and the total cost of the drugs, they've been around for a long, long time, $13. Now, you know, I'm minimizing the cost, because in addition to the cost of the drugs, there's cost of delivery of the drugs and cost for the health workers who supervise and the record keeping and da-da-da-da-da-da. But the average, and I just reread WHO's analysis for 2011, the average cost per case runs between $100 and $500 total. So that's drugs plus diagnostics plus supervision, I'd say. This is totally doable, and it's 85% effective, and yet, of that 8 to 9 million estimate, only 5.8 million are actually reported. The ones that are reported probably get cured at the rate of 85%, but there's 2 million missing, and we don't know where they are. We don't know if they're being diagnosed, treated with witchcraft, or in the private sector and not reported, and it's worrisome because half of them are probably highly infectious, and if they're badly treated, they create drug resistance. So I want to speak to those issues of those missing cases. They tend to be in poor and marginalized communities. They tend to be among the people most remote from access to care and diagnosis and treatment. They are probably in the poorest of the poor countries, although there are some examples of middle-income countries who have done a terrible job of managing tuberculosis. And in fact, some of the best tuberculosis programs are in some of the poorest countries in sub-Saharan Africa, in Malawi and Tanzania, very effective control programs, whereas South Africa has a terrible record. In fact, South Africa today, if I told you that we had 1,500 cases of TB in 2010 in Canada, that may seem like a lot of people, but the rate is it's under 5 per 100,000 population. The rate in South Africa, in spite of its gold mines and diamonds, is 993 per 100,000 in 2011. I just read the numbers, and I'd like to say those numbers out loud because I think it's a really important piece of information to have. Now, both locally and globally, this program that's been around since the 50s, that has these cheap $13 worth of drugs and the strategy for delivering it with directly observed therapy, can be evaluated at year end. So WHO has published this document that's about 300 pages long that tells you exactly how many cases got cured and how many were drug resistant, and they can do that because the program is really effective. But that program requires government commitment to assure that it remains in place. And the moment we think, whether global or local, that it's gone or it's going or it doesn't affect important people anymore, that's when the dog will bite us from behind, because this disease is clever. It's been around since the pharaohs, and it's not going away. The last case will be the hardest of all to treat, and it requires civil society that cares enough to come out and hear and listen and write to their MP to say, A, keep the program going. And in fact, Canada has just disbanded its Canadian Tuberculosis Committee because it's got other more important things to do. And in fact, Canada, through CEDA, is not increasing its overseas development support for things like TB, but cutting. And we've got to be able to say to Canada, let's look after our own issues, but also partner with the world. And lest you think that this is a frivolity when we have our own economic problems at home, I would submit to you that our investment abroad is out of self-interest. That in fact, it not only looks good and does good, it cures cases, saves lives abroad, but it actually, in a nice mathematical model by one of our best TB researchers, shows that it reduces the immigrant TB coming from that country where our investment has been. So in fact, it ends up being self-serving. So A, it's not gone, B, it's entirely doable, and C, it requires political commitment to do it. Is that enough passion for them?
That was really passionate. Thank you ever so much. So this is an open forum, and it's open mic, and these are terrific women. They're very knowledgeable, and you know, they would love to hear some of your thoughts, your observations. They would love to have a question. So who would like to be first? All right.
If you're looking at Aboriginal people and marginalized groups, why are the Métis excluded in the stats? Besides First Nations being funded by the federal government for health care and the Inuit.
Métis are always excluded.
I know. But even on the
yes,
control form,
yes,
it only has
there's a
First
long
Nation
history.
Inuit.
Yes. Well, there's a whole book section on why the Métis have been overlooked in much of what we do. But yes, that's a big problem, and there are more than a few people who are trying to redress the gap in knowledge about Métis health, and I know you're one of them. And Judy Bartlett and the Manitoba Métis Federation here in Manitoba, they have launched several studies of health among Métis people. I mean, another group that's not well captured in the information we collect are First Nations status, First Nations people who live in urban settings in the city. So basically, I was being flippant when you asked that question, because I know you and others are working very hard to try and get Métis statistics on health.
Yeah, because when I asked Manitoba Health why they don't have a category, they said, well, it'd be impolite to ask.
But
Yeah,
you know, I
very
have a response
yeah, go ahead.
that I actually don't, when I talk about Indigenous tuberculosis in Canada, I talk about First Nations, because you got a registry, and when you identify a case, you ask if they are First Nations, and you get their band number, and so you have a solid numerator and a solid denominator, and you can say that the rates are da-da, and they are unacceptably high. They're what, 40, 50 times higher than non-First Nations Canadian-born people. And you can do the same for Inuit because of solid identifiers in the numerator and denominator. With Métis people, I've never been comfortable that either in the numerator cases of people where I know they have Indigenous heritage but are not First Nations, and then equally I don't know on the bottom end. How many in Canada? Do we know that? So I don't know how to talk about it without knowing numbers. I mean, I think, yeah.
Manitoba, it's always 0 for the Métis. Saskatchewan, I think they had 4. But there's a higher concentration of Métis in Manitoba.
Yeah.
It just seems weird.
Yeah, but you see, in the setting where you're seeing a patient and identifying their ethnic heritage, they don't self-identify in my experience. But
even if I did go to the doctor and self-identify, there's no
tick box?
Yeah.
But there is in Alberta a tick box.
Not in Manitoba.
Oh, really? No.
My own take on it, which is not maybe what other people think, but is sometimes it's very convenient not to collect data because then you don't have to deal with it and address it. Yeah, that's my take.
We have another question.
What factors put a person at risk for TB?
Go ahead.
Clearly it can't
Yes.
be just economic, because your example of a physician that caught it
Yes.
treating a patient.
Well, let's, I can maybe talk in the context of Manitoba. We have about 135 to 155 cases per year in Manitoba of the disease. And that works out to a rate of around 10 to 11 per 100,000. And we have the highest incidence rate of TB in all the provinces of Canada. The rate is higher in some of the territories, but of the provinces, we have the highest rate. And about 3/4 of our cases, 2/3 to 3/4, are in people of Indigenous heritage, either status, First Nations or Métis, and the others are usually foreign-born. They might have come from another country in the 1930s, or they might have come, 2 years ago. There are a few groups of other people, but basically here it's either the disease is either Indigenous people or the foreign-born. And so there are factors that put you at risk of breathing in the organism, just getting infected. And that would be, for instance, living in a community where there's a lot of TB disease. Here in Manitoba, there are some First Nations communities where there's continuous disease. Also, let's say working in a hospital. So exposure. Another risk factor for exposure would be living in a crowded house. So if you live in a house with 12 people, which is common in some parts of this province, both in the north and in the north end of Winnipeg, all it takes is one person to come and have tea or babysit or stay overnight, and many people in the house will be infected, as opposed to if there are only 3 people in the house, a larger sort of space, then less likelihood that even if someone has TB and they come to your house, that you'll get infected. So those are factors. Traveling. We have people who are simply on an airplane with a coughing person who get infected, or people who take a trip backpacking around Thailand who become infected. So those are risk factors for breathing in the organism. But once you breathe it in, you know, Anne, for instance, said that she's got latent TB. I probably have latent TB. About a third of the world's population have latent TB, but we never get sick. But But progressing from sickness to disease, let's say you develop diabetes, or you have rheumatoid arthritis and your doctor says, I'd like to put you on this new medicine for rheumatoid arthritis. It's a miracle drug. It's called Remicade. Or I have asthma and I have to go on steroids quite a bit. Or I get cancer. The cancer and the treatment for cancer.
Or HIV.
Or HIV.
Biggest.
Yeah. So those are all risk factors. We think that there's some genetic risk factors and also maybe nutritional. And I don't know if this is a good time to say that there are two of the most brilliant researchers in Canada on the subject of vitamin D and the relationship of vitamin D to TB and also genetic factors of resistance and susceptibility are here. I'll just point them out. There's Neelafar Mukherjee is there, and Linda Larkham is there. And I don't know if you want to say something about vitamin D and genetics? You don't. Also, Linda's done work on housing and crowded housing. Issues. Some people say poverty. Well, how could being poor make you susceptible to TB? But being poor creates trouble in accessing healthcare. You have other priorities. You live in an area with poor healthcare facilities. You are overlooked by the healthcare system. There's still some racism and stigmatization in the healthcare system. Oh, it's only so-and-so who wants attention or is here every night. Or many of the patients in this province and probably the others who are diagnosed with TB, when you look back in their story, they've been to the emergency room 5 times with a cough, or weight loss, or sweating, or whatever, and they're sort of sent home with a script for an antibiotic, or Tylenol, or whatever. I'm not. It's. You know, I don't want to be too dismissive. It's not always that easy to diagnose TB. You know, sometimes it's the healthcare system's fault, but sometimes it's just plain difficult.
I wanted to ask you about the genetic factor. You know, certain groups seem to just get TB an awful lot, maybe several times. Have we done anything with that? The genetic breakdown?
Yeah, I'm going to force them to.
Oh, I'm sorry, but it's
no, that's
interesting.
good.
I can talk about that. We've been looking at genetics of the immune system. So certain components,
certain parts of the immune system that are driven by certain genes. And some of them are more active in certain groups of people and less active in other groups of people. So there's genetic variation across geographic regions, across cultural groups. And genetics likely do play, the genetics of the immune system likely do have an impact on disease susceptibility. But it's only one of the risk factors, and the socioeconomic conditions, things like nutrition and exposure are right up there. So genetics is probably one of those things that plays a part, but we actually don't know enough about it yet to say exactly how it's affecting susceptibility, but we do know it does play a part.
But I really want to say that even where you have the poorest of the poor in sub-Saharan Africa, in Asia, you can actually cure TB without knowing anything about the genetics with this proven 50-plus-year-old management strategy and treatment regimen. So, not suggesting that we shouldn't address poverty and crowding and find out more about the genetics. But while we're waiting to make those great discoveries and social interventions, let's keep delivering good program, and let's not let cases be missed because we physicians have forgotten about it.